moderating the session from now on.
Thank you very much, Dr. Rajesh, for that wonderful introduction. And thank you, AIOS, and very specially Dr. Namrata, Dr. Mahipal, and Dr. Rajesh for this invite. And we would move away to business straight away. And our first speaker this morning is none other than Dr. Deven Tuli. And he is going to take us through OCT and UBM in clinical practice. So over to you, Dr. Tuli.
Thank you, ma'am, and thank you for the opportunity to AIUS and to you especially. So if my slides are visible, I can go ahead. So I've been given the task of discussing OCT and UBM in practice. So moving straight away to this, it's that OCT in practice is not very old. I think it came into vogue following the Oct ancillary study, which was published in 2002, but it got popularity in practice about 3 to 4 years later in India. So we are just using it for the last 15 odd years. It was this study which showed that structure has immense importance in glaucoma suspects and ocular hypertension, because tools like the OCT can pick up what is known as pre-perimetric glaucoma a number of years before the first defects appear on field testing. Having said this, because our audience today is mostly general ophthalmologists and residents, I must caution you that perimetry still remains a gold standard. Unless you do the perimetry in a glaucoma suspect or ocular hypertension, how will you know if there are field effects when you do it first in a so-called glaucoma suspect? Then that patient does not remain a suspect for glaucoma anymore. If there are field effects on the first test, then that patient becomes early to moderate glaucoma depending on the field defects that are available. So the first test that still must be done in a glaucoma suspect and ocular hypertension has to be a perimetry. Having said this, ocular hypertension and glaucoma suspect OCT plays a major role in what I said in pre-perimetric glaucoma. If the field is normal, then you should do this at the baseline, because look at the last line of the slide. Progression is the key with OCT diagnosis of glaucoma. So please do this, because I know a number of colleagues who are depending only on OCT and not doing perimetry. That is something which I'm sure my colleagues today will all discourage you to do. Perimetry first and then OCT as a baseline if the perimetry is normal. So the problem with OCT, why we cannot depend on OCT alone in a glaucoma suspect or ocular hypertension in a first test. If you do OCT, you can't depend on it, because the problems are with the reproducibility. That means if you do the OCT test in a patient today, or even if you do it now, and if you repeat it after say half an hour, the report generally is different. This is despite the fact that in my practice, I do all the tests, OCT and perimetry, I try to do on my own, along with my optometrist. I stand and supervise. So a lot of errors like segmentation and others, like which others may talk about today, are not there or are negligible in my practice, because I tend to stand along the test. So it's the inter-test variation which is so large with OCT. If you do it today and half an hour later, or the next day, or the next after 6 months, the results may not be the same. And the other is the manufacturing. So with one type of machine to another, if the patient or tends to get it done from another doctor with another machine and comes to you, you do it, you cannot rely on the reproducibility. So that is the main thing. Hopefully this will be corrected with the software in future. So with the OCT, you cannot start treatment on the OCT alone if everything else is okay. But if you do it after 6 months on the same machine done by yourself again, and if there is progression, that could be an indicator for starting treatment. So remember, the mantra with OCT is, the basis of starting treatment with OCT is progression. Now, the backbone of the glaucoma analysis with the OCT is the nerve head map, and it is done at the 4 millimeter circle usually, so it's popular as NHM4. So if you don't have OCT in your practice and you want to refer it to a neighboring clinic, please order this test, and this is the one which will tell you so much as this slide is telling you, but I'll point out with normal versus glaucoma. So pay attention to this with the nerve head and the ganglion cell. So let's look at the, I'll be using this highlighter. The yellow one will appear suddenly. So you will see that in the left half, where it's normal, the cup is shown by the light gray area. The dark gray area is depicting the rim, and the RNFL, which is the thick and the normal still, is shown by the fire colors or the hot colors, which are red and yellow. Now compare this with the one on the right, where you can see the light gray area has increased tremendously. So the cup is enlarged. Correspondingly, the rim, the dark gray color, is thinned out tremendously. And this seems to be more than moderate to advanced glaucoma. Also, you will notice that the hot colors, the fire colors, have disappeared in the RNFL. So that is RNFL thinning. And remember that the RNFL fibers are usually the thickest inferiorly, followed by superior. And that is the take-home message from me today, that like you do in the disc examination, even in OCT, you must look at the inferior and followed by the superior parameters to have some credence towards glaucoma. So in the differential diagnosis, if there are changes only nasally and temporally, you have to be a little ginger in looking at whether it's glaucoma or it could be something else. But inferior changes come first in most OCTs in glaucoma, followed by superior. Keep that in mind. On the bottom side, you will see the normal are the ganglion cells. And ganglion cells, I'll show you what they mean in the next slides. And ganglion cells actually are supposed to get affected in glaucoma selectively. So in this, you can see that this ganglion cells are there in the normal, and they have disappeared more or less in glaucoma on the other side of the slide. Now, I told you inferior. Now look at the OCT image on the right side in this, and you will see that the inferior rim is not there. The cup is enlarged. It has eroded into the inferior rim. Correspondingly, the fire colors are not there in the inferior RNFL, but they are still there superiorly. And that is depicted in this, the double mountain peak that you see on the inferior, the lower graph. The inferior part is blunted out because the inferior RNFL loss is gone. And as we know that when the inferior RNFL or the inferior rim thins out in glaucoma, you pay attention to it. And correspondingly, if the inferior rim goes on structure, that should reflect on a superior paracentral defect on the field. And that is exactly what we found in the 64-year-old male patient who came to us as a suspect. But after doing these tests, it was established that he has early glaucoma and probably needs treatment. You can still see in this the right and the left OCT of a patient where again the inferior and the superior part are thinned out, just a reinforcement of the same. I told you that always you don't get such classical OCT images. But if you do, like in this patient, there is, when we've done this test over a period of time, you can see there is progression that is showing by the appearance of the red colors on the statistical map as they are. And this warrants this patient, when it was done by me over a period of every 6 months, is showing progression. This warrants treatment, in my opinion. And that is what we did. So ganglion cells actually are in the inner retinal complex, which are shown by the 2 red arrows, as you can see. And I told you the importance is that they are affected in glaucoma. And that is why this GCC can be used to differentiate whether it's glaucoma or sometimes neurological causes, which may be producing a masquerade. This test can be used. Keep this in mind. In the GCC printout, there are so many things which are there, but we look at the last one. Please, all of you look at the last part, is the standard deviation map, and the appearance of these red and yellow colors as signified by the significance map in the bottom is a reflection. So this patient seems to have more affection on the right eye than the left, but we need to watch very carefully on the GCC printout. And this again, you can just see inferior GCC in the right side, again inferior. Remember, inferior in glaucoma, that's very, very important. And in the other side, you have superior changes. Both of these need to be alerted. The patient needs to be alerted, and moreover, the doctor needs to be alerted. We need to lower the target pressure in this patient. So OCT as a tool in practice, what Chandrima ma'am has given this topic is glaucoma in practice, or OCT in glaucoma practice. See the advantages. In glaucoma, you can look at the optic nerve head, the RNFL, the GCC. I'll tell you in the next slides, you can look at the pachymetry and do the angle assessment also. And in a group practice, like most of us are, we can also look at the cornea and the retina. So this is becoming an important tool, and you must know more about the application of OCT in glaucoma like we are doing today. So let me reiterate the point I mentioned earlier. Can you start treatment if the patient has OCT defects on the first OCT done, only the OCT is having defects? The answer is no. Usually, no, you don't start treatment. And that is what a lot of us do actually is on a isolated red defect. It's popular now as a red sign or a red flag disease. You don't start treatment. However, you get alerted, like I said, as a doctor, you lower the target pressure. Even if you don't start treatment, you lower the target pressure in that patient based on those isolated sector RNFL defects on OCT. But if there is progression on OCT, like I've shown, and especially if you've done it on the same machine and done it yourself, then that could be an indication for starting treatment. So this is the crux of it. Beyond moderate glaucoma, I told you in glaucoma suspects and ocular hypertension, it has a great role to play. It must be done at the baseline. But beyond moderate to advanced glaucoma, OCT has a plateau effect, also known as a floor effect. So please be aware that beyond moderate glaucoma, when field effects have occurred, you must rely on field progression much more than OCT. OCT can be done, GCC can be done. You can also do OCT in patients who are not good performers on perimetry, but don't rely on OCT alone in moderate to advanced glaucoma. That is not correct. I am a big believer in, this audience will have people in semi-urban or semi-rural setup where they do not have access to OCT. So do not despair. You do a good disc examination with a 90D or a 78D lens, you can get a lot of information that the OCT gives you. However, if you have a fundus photograph or a fundus camera available in your vicinity, get that done also. That also gives you quite enough information about the structure like OCT does. So these in total would be about this. Then moving on to the anterior imaging part. Ma'am, I have about two minutes. Okay, so anterior segment OCT compared to the posterior segment uses a longer wavelength as specified here. And these are the images that you get, which are shown here. With the anterior segment attachments, you can also get pachymetry, so don't have to buy pachymetry separately. Now, UBM versus anterior segment OCT, both are used for anterior segment imaging. The advantage is you can see the ciliary bodies. Please follow the bold letters on the first line. Ciliary body, the peripheral lens, and also the peripheral iris. So these are the advantages. Look at the comparison, which is in the lower part of the slide, and see the bold one, the resolution. That is a huge difference. UBM pictures, I'll show you here. This is anterior segment OCT of the picture of the angle. Compare what it looks like and see how better the UBM picture is of the same. So resolution is vastly different between the two, and where available, yes, you can do anterior segment OCT. I would like the panelists to comment. Some in my practice or where I visit, some are even using Pentacam. So I don't know how good that is, but anterior segment OCT, UBM, and the application in glaucoma is you cannot use these two tools, anterior segment OCT and UBM, as replacement for gonioscopy. They are only used as adjunct to gonioscopy in special situations like corneal pathology where gonioscopy is not possible, or you want to look at, it can be also used as a patient education tool because these pictures are very impressive. I'll show you some pictures in the next slides. Compared to gonioscopy, yes, they are non-contact. Anterior segment OCT is a non-contact. UBM still needs contact. And the special applications, please look at the last two lines of the slide. The special applications where UBM is mighty useful are in anterior, the ciliary effusions, like we are getting a lot now of these cases in drug-induced glaucoma. Yes, this is a special application because the treatment of drug-induced glaucoma versus primary angle closure glaucoma is absolutely poles apart. So if you suspect drug-induced glaucoma, you don't have UBM, please refer it to a center which has it in the neighborhood, and it can pick it up very easily. Also with pigmentary glaucoma, as some of the pictures are showing us, and plateau iris. So I'll show you some pictures. Open angle glaucoma, I told you it's very good to educate the patient. Look at the picture. Open angle glaucoma, absolutely open angle. Subacute ACG on the right side, appositional closure in the lower left side, and chronic ACG. These, you can use it as a tool, and the patient sees these, and it is easier to motivate the patient towards treatment. YAC PI is done here. It has opened up the angle. We get, look at the right bottom picture, the PS in secondary glaucoma. These are the ones we get in uveitis and neovascular glaucoma. Traumatic glaucoma, you can see very nicely the split up ciliary muscle showing angle recession, and there's also an iridodialysis. A trab opening, it's very easy to pick up. You can see the drainage in the filter. And look at the last, the right side, it's showing a ciliary body detachment, and that caused a persistent hypotony. But similar picture you can get in ciliary effusion, where you suspect drug glaucoma. So anterior imaging, I think this is the last slide, ma'am. The anterior imaging, I must reiterate, it is only a supportive or an ancillary tool to gonioscopy. It cannot replace gonioscopy. Because look at the picture of gonioscopy synechiae. These are very difficult to pick up in inexperienced hands or in anterior imaging. And with dynamic gonioscopy, indentation, you can actually show indentation and show occludable angles, which again is possible with imaging, but requires a lot of imaging, a lot of experience. So I just wanted to say plateau iris picture is shown here. See how flat the iris is. It is crowding the whole complex of iris and ciliary body are jutting into the angle and crowding it. And plateau iris and drug infusion, ciliary body infusion is very nicely seen here. So I think this is what I had, ma'am, and thank you for allowing me an extra 1 or 2 minutes. Thank you for the opportunity again.
Thank you very much, Dr. Deven. That was indeed a great talk, very clear, concise, relevant. And we'll move on to our next speaker, Dr. Manish Singh.
I'm just removing the sharing.
Yeah, to stop sharing. Dr. Manish Singh, you can start sharing your screen.